Good evening, everybody. Very nice to see you tonight. Welcome to the second ESGE Paper of the Month series, Evidence-Based Medicine in the Endoscopy Suite. My name is Peter Siersema, and I will moderate this session together with Helmut Messmann. He is the president of the ESGE. Today we have two outstanding papers to be discussed. One paper is a paper from the upper GI. It's on GPOM. It will be published in the next few months in Gut. And the second paper is on the lower GI, and it's related to colonoscopy, of course, but also on the management of small polyps sized 5 to 9 millimeters. We have four outstanding speakers. Ryan Law from the US as the presenter of the first paper, Jan Martinek from Prague. He will be the discussant of this first paper. Then we have as the second speaker, Marina de Benito Sanz. She will speak about the colonic paper. And as a discussant, we have Monica Verlich from Vienna in Austria. So I'm looking forward to an outstanding and fantastic meeting tonight. And I would like to present the first paper. This is already the fifth year that we are presenting these webinars. These webinars are aimed to deliver high quality presentations on important endoscopy topics. And of course, it's also important that you participate in this meeting, and you can submit your questions online. And for this, you can use the Q&A box that's underneath your screen. So let's go to the first paper. The first paper will be presented by Ryan Law. He is from Michigan, and he will present on behalf of all the speaker or all the authors that you see over here. And the title of his paper is Gastric Peroral Endoscopic Myotomy for Refractory Gastroparesis, Results from an International Prospective Trial. Ryan, the floor is yours.
Hi, Ryan. Good morning, and let's start for this wonderful meeting. Yes.
Thank you, Helmut and Peter, for the opportunity to present this on behalf of all my co-authors and senior author Monica Schaub. So, you know, we all are aware of the burden of gastroparesis. It remains an incredibly difficult to treat disorder with increasing economic costs, as well as gradual deterioration in quality of life of many of the patients. Available therapies have shown kind of suboptimal efficacy with potential serious adverse events and oftentimes difficulty in obtaining certain medications, for example, to treat this disorder. There's a recent large multicenter study which showed that only 28% response is noted to standard of care therapies. Over the last several years, there's been increasing interest in the pylorus as an identifiable therapeutic target. And with recent advances in technology and endoscopy, this resulted in the introduction of gastric peroral endoscopic myotomy in 2013. Some of the early data on this topic showed high clinical success with a relatively low rate of serious adverse events. Now, I'll be the first to note that many of these studies were uncontrolled, and perhaps the rates of success were a bit ambitious. With that in mind, we aimed to undertake a 12-month efficacy study for GPOM for the management of refractory gastroparesis, as well as determining the safety profile. With secondary aims, our goal was to assess change in quality of life as well as gastric retention throughout the study, and with the hope of determining predictors for GPOM clinical success, which all of us would agree is likely the holy grail for this type of procedure. The methods I would go over, I would say this included 5 participating centers throughout the world. Our inclusion criteria, obviously refractory gastroparetic patients aged 18 years or older. We excluded patients who had surgeries resulting in resection of the antrum or pylorus, obviously. We also excluded patients who were on chronic opiates, as well as those who had a surgical pyloromyotomy prior in the past. So This is just a quick video demonstrating the G-POEM procedure. Starts as any POEM procedure with a submucosal lift. Mucosotomy is made, and then a short tunnel is created. Here we are at the point of the myotomy. A tunnel has been created. In this image, you can see from the 2 to 8 o'clock position is the pylorus. The hook knife is used to grasp the pyloric fibers, which are then gradually dissected, as well as a couple centimeters of antral musculature as well. Following that, the mucosal incision is then closed, most commonly with a series of hemoclips. The idea being that complete closure is achieved, limiting risk of infection moving forward. So results of our study: 80 patients underwent the gastric POEM procedure. 75 of those patients completed the 12-month follow-up. Baseline demographics, mean age of 49 and 71% were female, with a mean BMI of 26. Baseline GCSI was 2.8, with the overall mean disease duration of our cohort 36 months. Pre-G-POEM gastric scintigraphy testing demonstrated around 40% retention at 4 hours as the mean of the group. In terms of the etiologies, a gastroparesis, it was split 36% post-surgical, 22% were diabetics, most of which were type 2 diabetics, and then 42% had idiopathic gastroparesis. In terms of our clinical success, I actually missed a slide that I'm going to go back to. Here, this is the one we missed. So clinical success was a primary endpoint. This was the GCSI 2-week recall, a 5-point Likert scale ranging from 0 to 4 with 3 subscales on postprandial fullness / early satiety, nausea, vomiting, and bloating. Our modified clinical success was defined as at least 1 score decrease in the GSI with greater than 25% decrease in 2 of the subscales at 12 months. Initial clinical success was a GCSI score of less than 2 at 12 months. As we discussed, the gastric scintigraphy was performed prior to the procedure using a standard low-fat egg white meal. Patients were also asked to complete a 36-item short-form quality of life survey, and safety was measured in terms of the ESGE lexicon for adverse events by Peter Cotton. So we'll go back to where we were here. In terms of clinical success, overall, I would highlight over here, this is the main point. At 12 months, we had modest clinical success of 56%, with 68% of patients demonstrating a GCSI less than 2. When you look at the GCSI as well as subscales, the overall score of GCSI decreased significantly, as did each individual subscale, which is reassuring. Gastric emptying results, comparing pre-G-POEM and post-G-POEM, we also saw a substantial reduction in the 4-hour gastric retention. I would make note that only 66% of the patients enrolled had a 3-month gastric emptying study. I know that many of the centers had difficulty capturing our patients and having them come back. I would like to believe that that's because they were doing so well. But all in all, that is one thing that was a bit of a challenge throughout the study. 47% had a normal gastric emptying study at 3 months. And then we saw at least a 50% reduction in 64% of the patients included. Now, when we look at the safety profile, our rate of adverse events was in line with previous studies, around 6%. All were mild. We had 5 adverse events in total, all of which, like I said, were mild. 3 with symptomatic capnoperitoneum, and then one each with inadvertent mucosotomy and one with a thermal injury. All of these were managed intra-procedurally or one day after the procedure, and the patients recovered well. Now, one of the secondary aims of this study was to identify predictors of success. Again, this is likely the holy grail as it relates to gastroparesis and GPOM. In our study, we identified a baseline GCSI score of greater than 2.6, and then gastric retention greater than 20% at 4 hours pre-GPOM as independent predictors of success. With that being said, several studies on the topic have identified many potential independent predictors of success. So I do believe this is a bit of a moving target as well. So in summary, GPOM was safe and modestly effective with a 56% clinical success rate. We saw improvement in the average GCSI as well as subscale scores. Quality of life and gastric emptying improved as demonstrated. It appears that the GPOM outcome for those that responded was durable. The baseline independent predictors of success, for what it's worth at 12 months, gastric retention of greater than 20% at 4 hours, and then a symptom severity score prior to intervention, a GCSI of greater than 2.6. Based on this, our group was able to say that we believe that unselective use of GPOM is discouraged or should be discouraged. We should have multidisciplinary committees to select appropriate patients and decide where it fits in the algorithm. There's still a tremendous amount of work to be done in this area to answer these questions. With future studies aiming to identify selection of candidates, that may be helped by using impedance planimetry, the EndoFlip device, intraduodenal manometry, or even dynamic gastric MRI. But certainly a lot of questions to answer. We hope that this provides some baseline data of how we can move forward. With that, I will turn it back over.
Thank you very much, Ryan. That was an outstanding presentation, and I think you show us, I think, some of the results that we can expect for the future, and also what type of patients we can expect to have that will have a positive result. I think for the time being, we should move forward now to the discussant, Jan Martinek from Prague, and he will give his opinion. Also, we'll have some questions at the end of his presentation.
Yeah. So thank you, Peter. Thank you, Helmut, and thank you, Ryan, for excellent presentation. Ryan presented really an important prospective study, and this is in fact only one among two prospective studies we do have now in terms of GPOM in patients with gastroparesis. And here you see a summary of important studies, including our pilot series, and the treatment success ranges from 56 to 75% of subjects. You see also one study showed a treatment success of 81% of patients at 6 months. So there are really differences among studies. There is agreement among them that gastric emptying usually improves, but there is no correlation between gastric emptying rate and symptoms, which has already been known. The problem with gastroparesis is something unlike achalasia. If we have achalasia and we do POEM, we have more than 90% response rate. And these patients have amazing treatment success. And if there is no dysphagia or treatment success, we don't have to care about these patients. Gastroparesis is a different story. We only can improve the symptoms. We don't cure this disease. And if we improve symptoms by 50%, for example, there are remaining symptoms which are still important. And all studies proved that the treatment success can be above 50%, but it's not as high as 90%. So GPOM is not like POEM in achalasia. And I agree with Ryan that we should find a good tool how to select patients for GPOM, but we don't have any. We don't have any data because there are some problems. First of all, there is a lack of standard definition of treatment success. Each study uses different definition of treatment success. And if we define a treatment success as a decrease of the score by 1, and please note that the score CSI is ranges from 0 to 5, 0, no symptoms, 5, maximally severe symptoms, and decrease by 1 means from 5 to 4, it's really not a huge response. Of note that gastroparesis is a disease which is susceptible to a high placebo response. There are studies defining the treatment success as a decrease of the score by 2. In our study, we define the treatment success as decrease of this score by 50%. Second, we are mixing in all studies different etiologies, and maybe we are mixing apples and oranges, because we have diabetic etiology, we have post-surgical etiology, and we have idiopathic gastroparesis. And if you look how many of these etiologies were included in the present study, 41 idiopathic, 35% post-surgical, diabetic 24, and majority of diabetics were type 2. Other studies with much higher treatment success had the highest number of diabetic patients and more type 1. This could explain some differences among studies. There is also heterogeneity among predictors. Ryan showed the predictors from this prospective study, that the more severe symptoms, better response, and more severe gastric delay, better response. But other studies found that, for example, some endoflip values can predict treatment success, but there is no agreement about the cutoff and whether distensibility index or cross-sectional area. Severity of symptoms, severity of gastric emptying, type of symptoms, some studies also showed that can predict treatment success, that nausea vomiting response better than fullness, duration of the disease, or psychiatric medication. There is also an interesting question whether single myotomy is enough in some patients, that maybe is not radical enough to do one single myotomy, and then some patients need double myotomy. I will be back to this just in a few seconds. And also, Ryan showed that there were not too many recurrences. Abdel Fattah showed that there were recurrences in a rate of 13% per year. So we do not have long-term data, and we need long-term data. Here is a example. This was our patient. She did undergo the first GPOM without treatment success. It was a patient with post-surgical gastroparesis, and after GPOM we felt the pylorus is still spastic. We measured flip and distensibility was very low. So we offered her the second GPOM. You see that the pylorus is now, and we are cutting pylorus not at 6 o'clock as usually, but at 9 o'clock. And the second GPOM was really amazing effect. And there is a study showing that double myotomy might work better than single myotomy. So it's an interesting question for endoscopists. Endoflip, Brian mentioned the endoflip, which is a tool to measure how the pylorus is spastic. We have a balloon, we introduce it, it's not guide wire technique, so sometimes it's quite difficult to get through the pylorus. And we measure some parameters, including distensibility, and we see the image now, and we see that pylorus here is spastic. After GPOM, we can see that pylorus is no more spastic. But whether this technique can predict treatment success or diagnose pylorospasm, it is not clear, because there are no normative values, no cutoffs, no standardized protocol of measurement, not no individual variability. We believe this technique is promising, but it's not ready for the standard use. Some recommend to select patients according to response to botulinum toxin. I would like to underline that ESGE does not recommend the use of botulinum toxin as a selection or screening test to select patients for endoscopic pyloromyotomy. And also in a study of Ryan, there were 70% of patients who had prior to GPOM either botulinum toxin or stenting. And my question would be whether botulinum toxin predicted treatment success or not, the response to botulinum toxin. And as you see, there was a strong recommendation to this. Even I know that in the US, some colleagues, they still select patients based on response to botulinum toxin. But please note, there are 2 randomized studies showing that there is no advantage of botulinum toxin injection into the pylorus compared to placebo. Finally, I would like to show 2 slides that we performed a randomized sham control and crossover control trial comparing GPOM and sham procedure in patients with severe and refractory gastroparesis. This was presented at the UEG week last year. And this is the main results, that the treatment success, which was defined as decrease of the score by 50%, so a high threshold. This treatment success was 70% in intention to treat analysis versus 16% in the sham procedure. This paper has not been published and it's under review, so I will not comment these results, but I think it showed that placebo response can be really very, very high or quite interesting. For now, for the time being, I think it's still valid the recommendation of ESGE published 2 years ago, that ESGE recommends consideration of gastric or GPOM in carefully selected patients only, because it is an emerging procedure with limited data on effectiveness, safety, and durability. GPOM should be performed in expert centers only, preferably in the context of clinical trials. And here I have 3 questions to Ryan to if he can answer. Whom do you recommend GPOM now? So how do you select your patients? Does severity of symptoms matter? And when do you consider GPOM as highly inappropriate? Thank you.
Ryan.
So first of all, Jan, fantastic presentation. You raise a lot of very, very good questions, some of which I don't know if any of us have the answer to. Your first question in terms of who do I recommend GPOM to? You know, the way we do it here at Mayo Clinic is we actually have set forth a group of both physicians from our motility clinic, including Michael Camilleri and Adil Barucha, as well as me and a colleague of mine from endoscopy. And based on patient referrals, we have a group meeting and discuss if patients are appropriate or if there's still some things that we need in terms of testing or treatment options. So I don't think there is somebody that you could write down right now and say this person is an absolute ideal candidate, because I think that's a bit of a moving target. I think there's a lot of patient factors and procedural factors that may make them a good or not good candidate. One thing I would comment on from the procedural side of things, I don't believe that Botox should be used as helpful in terms of selecting or should include or exclude patients. But I also don't believe that the reason for not giving it should be anything related to the technical performance of the procedure. I can tell you that in many esophageal and gastric POEM procedures in patients who've gotten Botox, I don't find that to be, I find the issues related to sclerosing the submucosa or creating fibrosis as a bit of a figment of the imagination. I don't think it happens, at least not in a meaningful way. With that being said, your point's well taken about the multiple meta-analyses regarding that topic. So I would say that I would recommend a patient who we kind of agree on as a group has been through an adequate trial of prokinetics, has been through an adequate lifestyle change trial, and is still having symptoms. You could make the argument that proving pylorospasm on ADM should be mandatory. I don't know if I'm all the way there yet. I think it's got to be a good patient who can undergo the procedure. Also, mainly because I don't believe that the risks or downside of doing it is all that severe. For your second question, we did include patients who both had severe and non-severe symptoms. Let me minimize this. I do think that the severity of symptoms matters, but I also would say that it's difficult for us to put ourselves in the position of the patient. We use kind of subjective and sometimes objective data to figure out if a patient has severe symptoms. But for that patient, even though they may not fit severe on our GCSI, it may be a quality of life issue that's quite significant to them. So I would say that a patient who doesn't have, as we would classify it, severe symptoms wouldn't be necessarily excluded, assuming they've tried other less invasive options. I consider GPOM highly inappropriate as a first-line therapy, without a doubt. I don't believe there is any data at present to suggest that GPOM should be a first-line therapy, or that we have any data to suggest that it's a first-line therapy for even any subcategory of gastroparesis. I think, again, going back to what we both have said in our talk, identifying patients who are most likely to respond is really what we need to figure out. If we find out that patients with diabetic gastroparesis are ultimately the best responders, then that's useful information, and we can say that maybe if the idiopathics don't do as well, that GPOM should be moved further down the therapeutic algorithm. But I think anybody who's doing GPOM as a primary intervention, to me, I find that inappropriate based on the available data.
Thank you. So don't cut every porous you see. This is the message number one, because it could harm the patient. So I fully agree that this is not prime line therapy. And second thing, I would like to underline, after GPOM, even if there is a success, there is no cure, and you must take care of patients, and you must continue taking care of these patients, because there is only symptomatic improvement, but not cure. With GPOM, it's not over. Thank you.
Well, thank you very much, both speakers, of course. This was a very important discussion. There are a couple of questions in the Q&A box. One is from Daniel Schmitz. And he asks whether there are whether are relevant differences in the subgroups, such as diabetic gastroparesis. But I think you discussed this already a little bit. So is there anything else that we could say about this?
The only thing I would say, Peter, is that in our particular study, the clinical success rates across all subtypes were not statistically significant. They all responded at roughly the same rate.
Yeah. And what about diagnosis? How do you diagnose these patients? X-ray or endoscopy or manometry? It's a question coming from Alexandro Kiosov.
Yeah, so here we start with a gastric scintigraphy. We use a little bit different method here at Mayo than many places, but that's still our gold standard. Again, if we have any concerns or we need further information, there's a subset of patients who are referred for additional evaluation with intraduodenal manometry.
I would also say that in some centers that there can be the breast test, gastric emptying breast test can also be used as a valid alternative.
Ryan, I was listening to your presentation, and I wondered that the BMI was still relatively high in these patients. Is that the normal type of patient, or was this just unusual, maybe a little bit?
I mean, I think that just kind of, unfortunately, probably speaks to the kind of worldwide, situation with obesity and higher BMI in general. But I would say that a BMI of 26 in our study was probably on par with what we saw in most patients. I particularly, of the patients I contributed to the study, I can't think of any patients who were profoundly, undernourished or malnourished. So that, you could make what you want out of that to say, well, maybe patients weren't as bad off as it seemed. I don't know if that's true, but yeah, it was definitely higher than other studies for sure.
And the other thing is, of course, that the efficacy was 56%. So that means that 44% of patients was not effective. Does that say something about selection? Does that say something about the technique? What is your opinion there?
Good question. I think that my take on that is multifold. One aspect would be, if we truly are classifying these patients as refractory gastroparetics who failed other lines of therapy, then it's unlikely that anything else that could be offered would achieve 56% success rate with that low of an adverse event rate. So I don't take that you know, I guess where I go is the initial comment that I made saying that early studies suggesting an 80 to 85% success rate, I think is exceptionally unrealistic. And I don't believe that that's where this will kind of ultimately lie. Me and Bill Hasler, my partner in this, from the clinic side, we kind of felt before we even started the trial that, you know, 60% was going to be a win. Around 60% was going to be a win given the patient populations that were included from each center. So that's my biggest take on it, is that I don't know anything else that could be offered with that degree of success in that patient population. I do believe, you know, ultimately, like I said, finding the group that's going to benefit the most, or finding the technique that's going to benefit the most. You know, Jan talked about double versus single myotomy. I've done both. I do worry a little bit with a double myotomy. Am I going to set that patient up, you know, for dumping syndrome or something like that?
Yeah.
So there's still a lot of things that need to be sorted out.
Jan, any short feedback from your side?
Yeah, you see that gastroparesis is a complicated disease, because from first POEM until the recognition of POEM as a standard procedure, it took 4 to 6 years. And now from the first GPOEM, the publication was in 2015, I think. The procedure was 2013, and we are 22. So it's 7, 8 years, and we are still almost at the beginning. So it's really complicated issue, and I think any piece of evidence, it's important. And thank you for selecting this paper, this topic. And I hope we help the participants to think about this disease. And one important thing, please, all gastroenterologists should think on gastroparesis among dyspeptic patients, because this severe disease may be covered as a dyspepsia, or can be like a dyspepsia. And please do indicate if you have doubt the scintigraphy to diagnose gastroparesis. This is very important.
Well, I think that's a very important comment you make, because there's, of course, a gray zone between gastroparesis and dyspepsia. And I think that's very, very important to keep that in mind. Helmut, do you have any final comments, and or shall we move to the second paper?
No, it was a great presentation. I think Ryan and Jan covered all the topics. I remember when Jan did the first GPOEM in my clinic a couple of years ago and trained me, and now it's well performed in my clinic. But still, we have open questions: how to select patients best, how to diagnose the gastroparesis. And I think we still have to learn on this difficult disease, yeah. And we saw really the problems of different etiologies, and yeah, I hope that at least a couple of patients can benefit. And Ryan and Ian showed it clearly that in specialized centers, this technique has for sure its place and can really help patients. So thank you both for this excellent presentation. I enjoyed it. I learned a lot. It was, Peter, I think it was great to select this paper. Yeah,
I think so. I think so. And of course, an excellent presentation and an important comment. So thank you very much.
Okay, thank you. And now I think to just to keep in time. Now, last time I was not so in time as you, suggested. But now we move forward. We move now to the lower GI tract, and it's a really great pleasure now to have two female experts for lower GI tract, and we have a very important paper on cold snaring. It's not only in centers like GPOM. Cold snaring or polypectomy of polyps 5 to 9 millimeter is our daily practice for every gastroenterologist. And I think we need really good data, randomized trials to know how treating this kind of small polyps. And now I'm happy that Marina de Benito Sanz from Spain is presenting her randomized trial. It's a randomized trial on 7 centers in Spain, and congratulations to the Spanish society. You're so active regarding polyp treatments, detection, treatment, and so on. So fantastic, and although from my perspective as president, Spain is the leading country for ESGE members. So I'm really happy that we have now the Spanish group on board, and Marina will present her paper on behalf of the other co-author. She is the first author, and the paper is Efficacy and Safety of Cold versus Hot Snare Polypectomy for Small Polyps, 5 to 9 millimeters, in a multi-center randomized controlled trial. And after her presentation, Monika Ferlich from Vienna will discuss this paper, will comment this paper. She is the first author of our ESGE guidelines on management of polyps. So I think it will be an interesting presentation and hopefully an interesting discussions with our two experts. So Marina, the floor is yours, please.
Thank you so much. Good evening to everyone. There are my competing interest disclosure. And then European clinical guidelines recommend colorectal polypectomy for removal of polyps smaller than 5 millimeters and suggest it for lesions 6 to 9 millimeters. There are pilot studies showing important rates of retrieval failure in 6 to 9 millimeter polyps, and the evaluation of the horizontal margin is inadequate. The preferred method is the evaluation of the biopsies of the mucosal defect, as you can see in the photo. There are recent multicenter clinical trials employing biopsies from the mucosal defect margins, demonstrating colorectal polypectomy is not inferior to hot snare. There are recent multicenter clinical trials employing biopsies from the mucosal defect margins, demonstrating colorectal polypectomy is not inferior to hot snare. There is a single center trial reporting higher proportion of overall abdominal symptoms in patients undergoing hot snare polypectomy, but in the study, abdominal pain is measured as a dichotomous variable. The aim of our study is to compare hot and cold snare polypectomy for small polyps in terms of complete resection rate. Also, we assess the association between the polypectomy technique and adverse events, such as post-procedural abdominal pain and procedural and delayed bleeding. Between February and November 2019, at 7 Spanish centers, including all types of hospital, all the patients referred for colonoscopy for any indication were invited to participate. All 5 to 9 millimeter lesions were considered eligible. When eligibility was confirmed, the polyp was removed by hot or cold snare polypectomy as randomly determined. Randomization is made per patient, not per polyp. In this video, you can see how to perform cold snare polypectomy. There is a small polyp, about 5 millimeter polyp in the colon, and then we are going to make the polypectomy with cold snare. This is a block resection, and after that, the polyp was sucked into the working channel of the colonoscope, retrieving that for histopathological analysis. After that, after the polyp is sucked, it's very important the observation period of interprocedural bleeding. At this time, you can wash with water or not, and it's important to wait until 60 seconds or until to confirm that self-bleeding, interprocedural bleeding is self-limited and it is spontaneously stopped. You can see about 15 seconds after that, self-limited bleeding stopped, and then it's not need endoscopic clipping or any hemostatic mesh. After that, we take with a forceps the 2 biopsies from the right and left edge of the mucosal defect, and these biopsies are used to evaluate the complete or incomplete resection, as you can see. Okay. After the colonoscopy, the patient has to fill a post-procedure questionnaire regarding abdominal pain and adverse events. After that, a centralized telephone call is made by a single blind experienced research nurse asking about this questionnaire. All the polypectomy specimens were evaluated at each center. The biopsies of the mucosal defect were centrally assessed by a single blinded experienced pathologist. I don't know what's the problem, but my slides don't work. Our primary endpoint is the complete cross-section rate, defined as the presence of normal mucosa or burn artifacts in the biopsies from the margins of the mucosal defect. As secondary endpoints, we evaluate adverse events such as interprocedural delayed bleeding, post-procedural abdominal pain, and other minor adverse events. Also, we evaluate predictive factors associated with incomplete resection. Next, please. Next, please. This is our flow chart of our study, and then 1,500 patients were assessed for eligibility. 1,000 of them were excluded, most of them for lack from 5 to 9 mm polyps. After that, 500 patients were finally randomized, about 50% for each group, called a snare polypectomy. About 1,000 of each group is excluded for not presenting a polyp smaller from 5 or higher than 9 mm. After that, only about 100 patients complete the final post-procedural analysis set for each group. Next, please. Okay. In this chart, you can see that there is any statistically significant difference between polyp characteristics between the two groups. Size, morphology, location, histology of the polyp are homogeneously distributed between the two groups without any statistically significant difference. Our results, we don't found difference in resection rates between the two groups, called a snare polypectomy. As a curious finding, dedicated cold snare did not improve complete resection rate compared with conventional snare. Among endoscopists who perform more than 20 polypectomy, individual incomplete resection rates range from 1.5 to 14%. This is a curious finding that you have to pay attention. Next, please. Okay. In this chart, you can see our multivariable analysis, and the most important factor predicting incomplete resection was the endoscopist. Next, please. Regarding adverse events, overall adverse events were homogeneously distributed between the two groups. Interprocedural bleeding is homogeneously distributed between the two groups without any statistically significant difference. And it's important to see that cell-limited bleeding is more frequent in cold snare polypectomy group, but this is cell-limited bleeding that does not require endoscopic clipping or an hemostatic measure. Also, only 2 patients present delayed bleeding 24 hours after colonoscopy, and both of them require hospitalization, 1 for each group. In another 36 patients, there are only minimal post-colonoscopy rectal bleeding, which did not warrant medical attention. Next, please. In this graphic bar, you can see about the temporal evolution of abdominal pain. It's important to fix that in hot snare polypectomy group, about 18% of patients present mild or moderate abdominal pain about 5 hours after colonoscopy. On the other hand, in cold snare polypectomy group, only about 5% of patients present mild or moderate abdominal pain. You can see that the normal evolution over time in cold snare polypectomy group, abdominal pain is reducing.
This is the last slide from Marina, but I could present and maybe she will be back, hopefully. Incomplete resection rates found in this study resemble previously reported data. Paul reported 6.8% of incomplete resection rates for 5 to 9 mm non-pedunculated polyps. And the Crescent study, that was the gut study from Kawamura, reported an excellent 1.8% incomplete resection rate for cold snare polypectomy and 2.6% for hot snare polypectomy, but excluded sessile-serrated polyps and hyperplastic polyps, which are sometimes difficult to see the margins. Self-limited bleeding was more frequently encountered in the CSP group but there was no difference between the groups in rates of intraprocedural and delayed bleeding, finding that concurs with recent meta-analysis demonstrating the efficacy and safety of cold snare polypectomy. what is the most important point is that cold snap polypectomy shortened and reduced the intensity of post-polypectomy abdominal pain compared with conventional polypectomy. Also, it did not lead to decreased healthcare utilization. A hot snare polypectomy was the only risk factor for pain, and at 5 and 24 hours after the colonoscopy in patients whose polyps were all 5 to 9 millimeters, and wide range of incomplete resection rates among endoscopies. This finding is consistent with the CAR study, where incomplete resection rates ranged from 6.5% to 22.7%. And to conclude, one more, cold snap polypectomy is an effective and, of course, cheap, because we don't need current, we don't need a needle for injection, and safe method that shortens and improves post-polypectomy abdominal symptoms, and should be recommended as the standard technique for 5 to 9 millimeter colorectal polyps.
We will move forward to the presentation of Monica, and then after that we can all for together the discussion with our participants. Okay.
Okay. Thank you so much, Monica.
You're welcome.
So Monica, please.
Hello, good afternoon, ladies and gentlemen. Thank you for being with us. We have nearly 300 participants now. And now I'd like to present the strengths and limitations from this study from my and overall point of view. Please switch to the next slide. Yes, for me, the strengths of the study is that it's a randomized controlled trial. It's very important, and it's a multicenter trial with 7 Spanish centers, including primary, secondary, and tertiary care hospitals. So in Spain, everybody uses cold snap polypectomy, and the doctors attended to these studies. We have comparable numbers of patients and almost 400 of polyps. And the first randomized control trial investigating post-polypectomy pain rates. And the randomization was stratified by institution. And the next point, which is very good, are the very low rates of prophylactic clipping, with 0.8% in the cold snap polypectomy group and 1.8% in the hot snap polypectomy group. These low rates are mostly due to definition of bleeding, that the intermediate bleeding, that the interprocedural bleeding is bleeding lasting for 60 seconds. That's like we are also doing. If it's bleeding after cold snap polypectomy, I just do nothing for the next 60 seconds. I look at the clock, and then I let the coagulation works. If we put the water all the time, and if we do something, it will still bleed, but in most time the coagulation is working, and the bleeding stops. And what is very new, that you also had pedunculated polyps included and semi-pedunculated lesions, which were usually excluded from cold snap polypectomy. The weakness for me, also performed in the previous studies, is that only biopsies from margin were performed and no EMR after the polypectomy, as in the studies comparing cold snap polypectomy with cold biopsies forceps, because with EMR we have the whole polypectomy sites, and the low complete resection rates with 94% and 92.5%, and that the endoscopies to perform the procedure also took the biopsy samples. Performing comparison to other studies, yes, the Japanese study shows higher complete resection rates and also non-inferiority of cold snare to hot snare. We have also a randomized controlled study investigating post-polypectomy bleeding, which was much higher in hot snap polypectomy group compared to cold snap polypectomy group. In the Spanish study is comparable, and we also have a third study without bleeding and abdominal symptoms in 20 versus 2%. And now the current ESGE guidelines recommendation regarding those polyps was just a suggestion. ESGE suggests cold snare polypectomy for sessile polyps 6 to 9 millimeter in size because of its superior safety profile, although evidence comparing efficacy with hot snare polypectomy is lacking. But it's the guideline from 2017, and now we are preparing an update. Please move to the next slide. And I hope that our recommendation with those 3 or more randomized controlled trials showing non-inferior efficacy for cold snare polypectomy versus hot snare polypectomy in these polyps, I hope we can give the recommendation, and the guideline will sound that ESGE recommends cold snare polypectomy for sessile polyps 6 to 9 millimeter in size because of its superior safety profile and comparable efficacy. And now I have some questions prepared to Marina. Marina, how can you explain the lower pain rates in cold snare polypectomy group? Is it due to higher use of ambient air in hot snare polypectomy group compared to cold snare polypectomy group, or do you know any other reasons?
We think that ambient air is used in a few patients in both groups. It's about a very small number of patients receiving ambient air between the 2 groups. Lower pain rates, we can explain that about the burn injury of the hot snare polypectomy. We suggest that post-polypectomy syndrome is a high range of symptoms that we only diagnose the most important symptoms with the patient go to the emergency department without abdominal pain, peritonism, leukocytosis, but there is a wide range of symptoms, and we think this is an underdiagnosed syndrome, but most patients present abdominal pain at home and they not consult, but without our centralized telephone call, the patient is asked about, explain me what is your pain, explain me how are you, and the patient refers this abdominal pain that is underdiagnosed, and we related that with the burn, with the thermal injury of the hot snare polypectomy, we think.
Yes, thank you. Very, very good answer. Post-polypectomy syndrome. We should be aware of this, and therefore we should use cold snare polypectomy because we can avoid it. Okay, please move to the next questions. Are the complete resection rates too low in those small polyps? How can the complete resection rates be increased?
We think our complete resection rates are very heterogeneous. There is a lot of different endoscopies, and we don't know what is the reason with these rates are low. And we think we are projecting a new study in Spain that is called Polybeba, and then we are going to make an interventional education without our online course, suggesting whether intervention can improve the polypectomy rate between endoscopies. But we think this is a low rate. Yes, we agree with you, but it's very low for these small polyps. It ranges about 1.5, that is normal, or 30%. Okay, this is an important rate that we are thinking things to improve this rate.
Do you think this might be due to your scopes, because high definition scopes were not only used, and you also didn't use the optical diagnosis in your study? Or
in most of our centers we employ high definition endoscope. We employ not high definition in a very low number of patients, and we think this is not the reason. There might be other reasons like the age of endoscopy, the experience. We don't know, but the high definition is used in most of the colonoscopies.
Okay, thank you. Please move to the next question. And I think this question was answered during your presentation, because I've prepared without knowing your presentation. So can cold snare polypectomy be used for polyps with high-grade intra-epithelial neoplasia, do you think?
This is a controversial topic, but we think colon snare polypectomy is safer, but we do make the polypectomy, we can repeat colonoscopy and take biopsies from the mucosal defect and evaluate the complete or incomplete resection, or to evaluate there is interepithelial neoplasia in the mucosal defect. On the other hand, hot snare polypectomy burn the mucosal defect, and it can be safer. It's explained that it's safe, that can burn the mucosa and it's most safer. But in our opinion, interepithelial neoplasia in 5 to 9 millimeter polyp is a very infrequent finding. But we think colon snare polypectomy can be used, and if you find the interepithelial neoplasia, you can repeat the colonoscopy and take biopsies to confirm the diagnosis, we think.
Yes, it's very dangerous question, and good answer from your side. I think you had one carcinoma in situ in one pedunculated polyp.
One, yes, only one. In our 18 polyps, only one.
Yes, and it was removed completely.
Mm-hmm.
Yes, but I think we have to wait to doing this.
It's a very infrequent
discuss
finding.
it with Michael Burke, and he tells me don't do it. So yes, how was the bowel preparation assessed?
We employed Boston preparation bowel scale.
Okay.
In all centers, we think.
Okay. How was the polypectomy time? Because I'm always discussing with the old endoscopies in Austria who always make injection and make EMR of every tiny polyp. And I advise them to start with cold snap polypectomy because you don't need needle, you don't need injection. How was the polypectomy time in your study?
In our study, we don't measure polypectomy time, but it's important, it's an interesting finding, but we don't know how to start this time measure, when the nurse assistant prepare the electrosurgical unit, prepare the patient, or when the snare is introduced into the working channel. We don't know how can we start the time to measure the polypectomy time, because hot snare requires more time of preparation of the nurse assistant preparing electrosurgical unit, and this time is very difficult to measure, and we don't know how to measure this time. For that reason, in our study, we don't measure polypectomy time.
Okay. Yes, in the previous study, I think the polypectomy time of cold snare polypectomy was faster than from snare polypectomy. I don't think that there's comparison between hot snare, but yes, it's difficult to measure. Maybe with starting to insert snare, but everything else.
But all the time preparing the electrosurgical unit, this time, how is measured?
Yes, but the overall colonoscopy time was same between the groups. So in your study, so okay. How can you blind the pathologists for assessment of biopsies of the mucosal defect? After hot snap polypectomy, there are probably cautery effects visible on the margin.
Cautery effects are visible, yes, and it is, we can blind the pathology for that. But we make a single blind pathologist, a central pathologist in a central hospital, which don't know the same pathologists who make the histopathological analysis of the polypectomy specimens. And it's blind about the polyp, about the endoscopies, about the center. He only received the biopsies from the mucosal defect. And he only analyzed these biopsies with a code, with a number. He don't know details about colonoscopies, endoscopies, the histology of the polyp. He don't know that. He's blinded in this reason. Cautery effects are visible. We can blind the pathology for that.
Thank you for Marina. Now I've finished with my questions. We have some questions from the audience.
Yeah. I mean, one question always occurs is we're talking about very small polyps. How do you measure these polyps? Is it 8 or is it 9 millimeter or is it 10? Still challenging. A total simple question, but it was now also from the audience. How should we measure polyps?
We compare with the snare, the 10 millimeter snare.
Okay.
And with the open snare, we compare the diameter of the polyp with the snare. This is in our protocol is the way to measure the polyp.
Yeah. Okay. It's a rough estimation using the snare. Another question is always, should we lift the polyps before resection, even for cold snare? Do you think it's necessary for the small polyps?
I don't.
No lifting necessary.
No,
maybe
everything no.
No, maybe for larger polyps in the future. We know that cold snaring is also of interest for polyps larger than 15 millimeter, 20 millimeter. If you resect a polyp in the ascending colon, let's say 20 millimeter, would you lift it?
In this case, we think it's probable to need lifting. Yeah, there is we don't have any experience with this type of polyp. Our study only is from front to 9, but with higher polyps, we think it can be necessary lifting. Yeah.
And is there a need to prevent bleeding, to use clips or something like this? If you have once, after resection, you have the feeling this is a much worse bleeding. Is it necessary?
In higher polyps, I think might be necessary. Yeah. In a small polyps, we have demonstrated it's not necessary in most of them, but in higher polyps, I think might be necessary.
Yeah, I think that are the most questions in the chat. And looking at the time, we want to be really. Peter, you are unmute. You mute.
Sorry, maybe one question left, and that is how important is this dedicated thin snare wire snare? Is that really important, or can you also do this with one snare that you use for hot and cold snaring?
We demonstrate dedicated color snare did not improve complete resection rates in our experience.
That's the finding, but I mean, that's always a question, of course, and that's also what the reps from the companies tell you, that it is better to use a thin snare.
Yeah.
But the dedicated snare is cheaper, therefore we use it, and it's easier to cut. And regarding the discussion of injection, so I remove many large polyps and up to 4 centimeters with cold snare in piecemeal. You can do injection, but you don't have to. If you do injection, it's easier to cut. So only reason for me, if it's not cutting properly, I inject, it's easier to cut, and I can proceed for fast.
Great. Maybe a last question from my side to all of you. How expensive is cold snare in your country? The device. What costs a cold snare in Spain, in Austria, Netherlands? In Germany, it's about 15 euro. 13
euros, the 9 millimeter snare.
Austria is cheaper, obviously.
In Spain, I think 20 euros, 22 euros, more or less.
Peter?
Netherlands is about 15.
15. Okay, somewhere between 15 to 20 euros.
Depending how you negotiate with the company.
I think so. Okay, I think we are at the end. Fantastic presentation from everybody, from you two. Again, Jan is coming back, and Ryan, thank you for joining this second paper of the month webinar. It's always fantastic to discuss with authors of the paper, their paper, and have experts asking them the weakness and the strengths of this paper. So great job from everybody. And you saw we had almost 300 participants. For March, we will select other papers for sure. As you know, these papers are not in press, so it's just online. It's so fresh that you have some advantages from you compared to your colleagues. You know really from the top experts the very newest data. Now I would like to close now our session, and I cannot close without announcing the ESGE days in April. As you know, Corona is still here, but obviously it's going down in each country. The numbers drop. Even now in Germany, we are still high, but compared to our other neighbors countries, we also had the peak last week. The numbers go down. The politics decided that in the 20th of March in Germany, everything is possible. So I expect that the other countries are much faster. And for sure, if nothing happens in between, we would have a great Congress in April in Prague, which is hybrid, but you're welcome. I'm sure there will be no severe restriction. Otherwise, there comes a new mutation, but hopefully, cross the fingers, it won't happen. The registration is open. Please look at our web page, early bed registration, and you see a lot of wonderful events we are now preparing. So the live endoscopy, concurrent sessions, international scientific partnering societies, a lot of hands-on training sessions, and a huge faculty from 35 countries. So welcome everybody to join us in Prague. Next slide. Yeah, there are a couple of benefits. It's not only this ESGE tutor. We have so many other interesting offers to our members, like the journal, cheaper registration, app, though it's worth to become a member. I know that we are still a growing society. It's a pleasure to be president of this great society, and we increase every month, I would say. Now we will continue our webinars next week. A new series of webinars. We call it the live endoscopy webinar. We will demonstrate live procedures which are pre-recorded. We start with this webinar from our unit in Augsburg with my co-worker, Dr. Ebiko, Dr. Probst, and Mariana Avatinakis. He's one of the authors of the guidelines for management of duodenal adenoma. And although George Webster and Mark Bartet will be here, and this is what you will expect: live procedures during live endoscopy meetings, and you will see how we handle this type of polyps in the duodenum, in the papilla, how we prevent complications, and so on. So you're welcome next week. It will start at 6:30 until 8 o'clock, so 90 minutes. Came a bit earlier, but enjoy this live endoscopy session. And for now, I would like to thank everybody, the presenters, everybody behind the scenes. So thank you to Gabi and to Dave, our team, who is doing a great job for this webinars. And sorry that we had today some connection problems. It's not because of Dave or Gabriela or Marina. It's just because we are all together worldwide. It's a web. So thank you for being here and enjoy the evening. And for those who are interested in football, enjoy the Champions football. Bayern Munich is playing against Salzburg, Monica. So it will be an interesting match. Germany against Austria, and yeah, have fun. So good evening, everybody, and see you next week.